It's me?
Yeah, please.
Okay, thank you. So, everything was said. Excellent talks, but, yeah, okay. I will talk about nasal measurements. The enemy of nasal examination is nasal speculum. You should examine the nose without nasal speculum because you cannot evaluate the nasal valve. So, I am doing these nasal measurements for a long time, and I can tell you 5 types of measurements. The last one is experimental, and I have all these machines in my department. This is rhinomanometry. It's the measurement. At a certain pressure, you close one nostril, and then you measure the flow on the other side. So this is airflow. So at a certain pressure, you measure the airflow here. You measure the inspiration, expiration. You measure it unilaterally. But it's mainly helpful for after decongestant. Otherwise, it's not very helpful to decide the operation, to decide the indication, but if it allows, you can diagnose the nasal valve obstructions in these cases. The problem with anterior rhinomanometry is if there is a complete obstruction on one side, so you cannot measure the nasocoanal pressure difference. Okay? You cannot measure this difference, and also if there is perforation, you cannot measure the pressure. So in these cases, it's not helpful. And in many cases, there are unilateral obstruction. And in these cases, you can perform posterior rhinomanometry, but this is also not reliable because of the palatal shape and position. So there is another measurement, rhinoresistometry. This is a combination of anterior rhinomanometry with computer assistance. What is different from anterior rhinomanometry? In anterior rhinomanometry, you measure the airflow, but in rhinoresistometry, you measure the resistance. So if the resistance is high here, you think it's nasal valve area, or how is the resistance? You can understand it during the inspiration and expiration. So this is not different from anterior rhinomanometry, but it shows us the resistance more clearly. And this is long time rhinometry. You follow the patient for 24 hours. This is very helpful, especially in sleep apnea patients. You measure the heartbeat, and you measure the airflow and respiratory frequency in this way, and you come up with these types of curves. You look at the heartbeat and airflow, and you compare them. You have an idea about the nasal obstruction on the heart. So, the rhinomanometry shows you the degree of obstruction and the cause. Acoustic rhinometry gives you the geometric measurement of nasal obstruction and localization of the obstruction within the 5 centimeter. And long time rhinometry is the 24-hour registration of respiration frequency, volume, and heart pulse. If you ask me, I have all this stuff with me. Which one do you use? I don't use any of them, because it does not help me in planning the operation. It shows you only before the decongestion and after the decongestion. It helps you. The decongestion helps. If you want to understand this, it helps. But you can also communicate. So, indeed, the lectures was very nice. I have reverse phase microscope. I have microscopy. I stopped doing a nasal smear because generally, all of my patients, over 90% is eosinophilic. So for eosinophilic, I don't do nasal smear anymore. And also reverse phase microscope I use only to see, it's wonderful, to see only the ciliary bead. And the ciliary bead, you know, we changed the name immotile cilia syndrome. Why? Because there are some patients with motile cilia but not functioning cilia. So for this reason, in these patients, if I suspect the ciliary dysfunction, I use this system. And regarding allergy tests, generally we perform allergy testing if we want to give immunotherapy. Otherwise, we do it. But by talking with the patient, you understand from the symptoms whether the patient is allergic or not. It's seasonal or perennial. The interview, the talking, the history give you the guidelines. Thank you very much.
Okay, good afternoon, everyone. So, I had to put that slide of disclosure because being an ENT surgeon, we use instruments left and right, and there's so many instruments to choose from. So, speaking about nasal obstruction, and there are so many ways of evaluation, I'm going to skip this as Mario already explained a lot of things, except maybe talking about obstructive sleep apnea, which, as Peter mentioned, it comprises 80 to 90% of my practice. And shifting a patient from a mouth breather to a nasal breather is what I try to do most of the time. And thank you for that talk a while ago, John. I enjoyed that. So, okay, we know all about the study of Wang. It's all about resistance in the passageway. It's all about the area that is most responsible for us not breathing well, computational flow dynamics. Okay, and nasal obstruction, we want to open up the passageway because of so many concerns, so many reasons. Patient can't breathe well, so he starts breathing through the mouth, or whether it's a polyp or a mass there, definitely we want to evaluate. And if we want to correct something, we want to solve something, the easiest way would still be what we're already doing every day. And in fact, since the conception of the endoscope, things have been really much easier. And when we go on YouTube, we want to look at an endoscopic surgery, we base it all on that. So for me, this is the bread and butter, okay? You want to look at the deviation, you want to look at the polyp, use the endoscope, okay? And when I actually do radiofrequency in the clinic, which is quite often in a week, you can see the turbinate shrink real time, and when you're done with it, all of a sudden the patient says, I can breathe. And so this is endoscopic or even just direct by using a nasal speculum. But of course, it's more dramatic if it's by direct nasal endoscopy. Okay, of course, if cases are a little bit more difficult and they have more symptoms related to rhinosinusitis, then CT scan is indispensable. Okay, you can explain a lot more, especially as the disease is not just related to nasal obstruction, but also to an infection. Of course, as was mentioned by my co-panelists, acoustic rhinometry, rhinomanometry, but for acoustic rhinometry, I have to mention, and it was pointed out by Mari to me a while ago, that in a study that was in a journal that was published by Jacqueline Correa, if the MCSA, the minimal cross-sectional area, is about less than 0.6 centimeter, that may predict the the compliance of a person using a CPAP. So although that was, as it was mentioned in that literature, it may also help. It may also help. Unfortunately, as what Mari mentioned, in the hospital where I work with, we don't have an acoustic rhinometry. Now this is important, and I'm glad that Peter showed it a while ago, because I'm going to go one further, okay? So when a patient has nasal obstruction and has sleep apnea at the same time, and obviously the patient has congestion, I tell them to use a nasal decongestant. Plus, since it's obvious that the bed partner says that they are mouth breathing, I also put a chin strap. Okay, so use the nasal decongestant, use it every day, but just in the evening, and put a chin strap. And I tell the wife, tell me how it goes. Is the snoring less? Much better. Is the apnea less? If they have those less breath pauses. And this is also a very good way of evaluating nasal obstruction. Okay, so talking about comparing CT scan and direct nasal endoscopy, yeah, it works. Okay. Endoscopy, not just for nasal endoscopy, but also for chronic rhinosinusitis. But for cases with negative endoscopy, but they have symptoms, then we do a CT scan. So having said that, the best way or ways, nasal endoscopy, absolutely. CT scan can be indispensable, only because I don't have acoustic rhinometry, but it works as well. It gives you an evaluation. And of course, for patients who do have a history of not only nasal congestion, but loud snoring, witnessed apneas, daytime tiredness, a little bit of a bias there, but these are the patients that come to me. I make them undergo a nasal decongestant trial. And you have about 5 minutes left, Peter, 4 minutes left.
Thank you, Mike. Okay, so you can just, I'll take this one. So the panelists asked me before we did the session on email, should you assign the topics? What if we overlap? And I said, I want to see if there's overlap, because if you overlap, then there's a consensus. If you don't overlap, there's not a consensus. So it was good to see that there's some consensus, but notice that a lot of it is technology dependent. And you know, Michael has the most elaborate system. I can't believe there's anything that organized in Italy. You may be the most organized guy in Italy, because usually in Italy nothing is organized.
The same
So that's pretty impressive that they have that system that they go through. But who has a lab like that? Anyone raise their hand? How many of you have acoustic rhinometry or rhinomanometry? Exactly. So what do you do in your office? This is all high-tech stuff. I don't do any of this stuff except allergy testing, nasal endoscopy, and CT scanning. Okay, why is a CT scan very important? Nobody brought it up. You cannot see a concha bullosa without it. You can't tell you have a concha bullosa, which can be very big, without a CT scan. Am I correct? You can predict a concha bullosa? No way. So you can't. And you can find huge concha bullosa without having, with a CAT scan, you wouldn't know they were there. Can you put up my slides for a second? Do you guys have my slides for a second? So, questions. There's some simple things you can do in the office that no one brought up. Can you put the slides up, please? History of orthodontic care. If the person said to you that they had braces, you can be guaranteed they had nasal obstruction. And if they couldn't afford braces, just look in their mouth. Do they have crooked teeth? Do they have a high arched palate? Do they have any issues with TMJ? Do they have bruxism? Do they have an overbite, a crossbite, underbite? Look in the mouth. You heard Dr. Walker talk all about it. Don't only look in the nose. Do they have a scalloped tongue? Right? Do they have scalloping all along the tongue? Classic mouth breather. That tongue has to go down behind the teeth so they can breathe through their mouth. You get a scalloped tongue from the indentations on the teeth. Very simple. Don't have to put anything in their nose. Just look in their mouth, ask them that question. And the forensics of the mouth don't lie. It's like, forensic files. You're going to get the answer by just looking in the mouth. Positional change we talked about, patient being up by laying down. We lay them down in our clinic. We actually ask them, lay them down, 15, 20 minutes, take a look in the nose afterwards, see what changes. I noticed that, Michelle, you decongested the patient, then you looked in the nose with the endoscope. Yeah. So I always yell at our fellows, never decongest the nose until we examine the nose, because you can see a lot of issues. You can't tell mucosal color after you've decongested. You're going to get a pale nose. You've decongested everything most of the time. You're taking the blood out. So it's hard to see allergy in a situation. They all look pale. So we don't do that. Vasomotor rhinitis is a big problem that's underdiagnosed. So when you do allergy testing, one of the things you're looking for is it negative? But the patient has a lot of congestion and rhinorrhea. I didn't bring any pictures to show you, but you can even see it on a CAT scan. When the nasal cycling is super exaggerated, one side almost shut down, the other side wide open. That's usually a vasomotor rhinitis problem in those patients. And sometimes you have bilateral congestion that doesn't respond to decongestion. So one of the issues you'll see is if they don't respond to decongestion, that's vasomotor rhinitis, without question. And then, again, exercise intolerance. Do they have any problems when they exercise? Do they mouth breathe when they exercise? Kids don't know. You got to ask the parents. But adults will know. They say, yeah, I usually have to open my mouth when I exercise. Because when oxygen on demand is different than oxygen at rest. And then, so we get a CAT scan on everybody. We do a nasal endoscopy without any decongestion. We get a CAT scan. We get allergy testing if they haven't had it done. And in my opinion, why do you need acoustic rhinometry to see a septal deviation or a big turbinate or polyps or any of that stuff? You can see it with the scope, like Michael said.
Of course, that's what my experience.
Yeah.
But I have one objection.
Sure.
To this slide. The last one, CT sinus is imperative. This is valid for adults. In children, in young children, we should avoid CT scan. Cone-beam CT scan has low radiation.
Yes.
But many people do not have this. If they refer the patient to normal CT scan, the radiation is very high for the children.
Correct.
I am talking about the children.
Sure.
Because we should inform our colleagues not to have CT scan unnecessarily.
So we only do cone beams on our kids.
Yeah.
That's all we use. Like you said, John says we have one in our office, in his office, so we use them for that purpose. But you're absolutely right about that. The radiation is very low. But on the kids, they come in, you look in the nose, you can't see in a 4-year-old's nose very easy. You're not going to decongest them and have them sit there. They don't want you to go near them with that scope. You can get a little bit inside. You get a CAT scan, you see a concha bullosa the size of a lemon. You're like, whoa, no wonder why. Anyway, so interesting topic. It can be very simple or it can be very complicated. You can go to Mikkel's office, be there for 30 minutes and get all kinds of stuff done. Very interesting. I never knew you did that. It's really very interesting setup that you have. We don't have that. We don't have the technology to do that, so we just do the simple things that we talked about. But it's interesting to see that, there's a lot of ways to skin a cat, and that was the purpose of this, because it's a tricky topic. And so I thank you all for your attention. And we have a question. You want to put that question up, Azita? Okay, we'll put the question up for 1 minute. Would mouth breathing and forward head posture be good? Yeah, exactly. That's classic, right? No question about that. About head forward posture and mouth breathing. Dr. Walker is going to talk about that later. Do you have experience on patients who do not even realize they have nasal obstruction but with very severe intolerance? Of course. That's the whole point. That's where the CAT scan comes in. You get the CAT scan, you can show them on the CAT scan, look at your nose. How could you say you don't breathe? Your nose is so twisted. We have a normal CAT scan that we show them also. Once they see the normal one, and then they see theirs, they're like, not even a question, not even an argument, not even a discussion. They say, oh. The only thing they say is, oh, I see. It's very simple.
But I agreed with Professor Onerci that for me, CAT scan is not imperative in every patient. For example, if you have an allergic patient that you make skin test, prick skin test, it's positive to skin prick test. It has a good response to therapy, to medical therapy. Why do you do CT scan? What do you need?
What if they
CT
have
scan?
more than that? What if they have much more than allergy? What if they do have sinus disease? What if they do have big conchobulosa?
Could be, but nasal endoscopy negative, allergic skin prick test positive.
Yes.
You make
Well,
therapy and you
but
don't
your
need
nasal
CT scan.
endoscopy is not sensitive enough. No way. Guaranteed. I'll show you scans of people. You'll never know you'd see that with endoscopy. You can't.
I don't know, in Italy we have problem to make CT scan to all the patients with
understand.
nasal
Okay.
obstruction.
They're telling us we got to end here because it's time for lunch symposium? No, we have another symposium. Okay. We have to get off the stage.
We can debate later.
We can talk about it later. It's a controversial topic on purpose.